Good afternoon from Miami Beach, home of Neurosurgical TV. Today we have the honor of hosting the Yemen the Yemen Walter Dandy Club that has 4 presentations, and we'll let Ahmed Al-Ghameni, the head of the group, run the show. Good day, Ahmed.
Hi, dear John. First of all, thank you for hosting this webinar. Here is Ahmed Al-Ghameni, the president of Walter E. Dandy Neurosurgical Student Club of Yemen, and also a marketing administrator at Abdurrahman University of Neurosurgery, which is considered the first online academic degree in neurosurgery worldwide. It's my honor to have this great webinar with great professors from around the world. So the first presentation and show will be with Professor Salim Abdurrahman, who is the founding and chairman of the neurological surgery at St. University, and also the global president of the Walter E. Dandy Society. Hi, Professor Salim.
Thank you, Ahmed. Thank you for the excellent work you're doing in creating the Yemen Club for us, and the amazing connections that you're creating around the world for your country. I want to recognize John Bennett for all his efforts around the world to transmit education in the field of neurosurgery. Also recognize Dr. Takashi, very late at night in Japan. He's here and he's been very involved with us, and his efforts are tremendous. So without further ado, the topic we were given today was to discuss the anterior part of the skull base. So what I'm going to do here is to engage you on this presentation, but I want to make it fun because we have people from different levels who are joining here, and I wanted to make it a little bit more interactive and ask some questions as we proceed along here. Okay, so let me do this here. Okay, so let me bring this. So today, so we're talking about an area. I'm going to talk about an area this small right here. So this is the anterior clinoid right there. Okay, anterior clinoid. The internal carotid artery enters the subarachnoid space right from underneath the anterior clinoid right here, right next to the optic nerve. I'm going to discuss this area right here as part of the symposium today, and discuss the anatomic or surgical relationship in this tiny little baby area that are so critical for skull-based surgeons and vascular neurosurgeons. Okay, so, and I want to interact with the students as well. And what I'm going to use here actually will make it easier is the first couple lessons in my module. Let's see, let me share. Nerve. If you look at here, so let's see how I make this big. So essentially, looking from the front, we're looking at the carotid artery here. Okay, let me do this. So this is the internal carotid artery here coming up. At this level is where I showed you is the anterior clinoid. Okay. Then the carotid artery will continue to go this way, of course, to divide into the anterior cerebral artery and the middle cerebral artery. This relationship right here is of critical importance, which is the optic nerve right next to the carotid artery here. That's the other side, of course, a chiasm. Okay, so I just want to talk about this region a little bit. Okay, and I want to just kind of go over that and make sure that we understand the surgical anatomy of this region, which is so important. Okay. In this depiction, this is a cut portion of the optic nerve. That's another portion. That's a right optic nerve, and this is a left optic nerve. look at this very important relationship between the carotid artery, our portion that we're talking about, the suprachiasmatic portion, and the optic nerve. So that will become an important thing, especially when I talk to you about the surgical implications of what is going on here. So for this segment, what we're going to do, we're going to appreciate this relationship of this artery as it enters the suprachiasmatic space. We are going to look at its main branches, okay? That will going to be coming off here, 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 and another small one here. And we are going to talk about the pathologies of that affects this artery. Specifically, of course, we are very interested today to look at the surgical approaches to this artery. How do we get here? How do we get here safely? How do we do surgery in this region? And what kind of surgeries we need to be doing in this region? Next, I would like to take you through a three-dimensional model to expose the internal carotid artery. I want you to appreciate here that we have a craniotomy we call a frontal temporal craniotomy right here, okay? And specifically, the name of this craniotomy is a pterional craniotomy. The other thing I want you to notice is this specific structure right there that you're seeing, that I want to expose to you right here, and the best way you could see it is right there. That is our optic nerve. Now, as you know, and I've been discussing this with you, the close relationship between the optic nerve and the carotid artery that I described. So the carotid artery will be here, deeper in, below the bone, and that's the optic nerve. So now that you three-dimensionally understand where the optic nerve, of course, that's the location from the front of the anterior clinoid, from inside the orbit. So that's, I want you to connect those dots. The orbit right there, it has a close relationship to the carotid artery. So by looking at this three-dimensional model, it gives you an understanding for us to expose the carotid artery. We somehow need to go from here, from this point here, to that point here. How are we going to go from there to there? By opening the area that we are calling right there, that I'm going to show you better. We're calling the sylvian fissure. By entering the sylvian fissure, which is between the frontal and temporal lobes, it will allow us to access the cistern in which both the carotid artery and the optic nerves sit. Now I would like to, okay, so let's look from above. We're looking from above down at a cadaveric dissection, and let's go through the structures. So just you remember, I showed you from one side, this is the area of the anterior clinoid, okay? That bone. We showed you from right side. Now we're showing you both sides looking from above down. So imagine the patient is, you're sitting at the top of the head, the legs are away from you, and you're looking down. So this is our friend, the right optic nerve. This is the left optic nerve, okay? That's the relationship. You see the carotid artery enters this region below the optic nerve, which is entering right here. So you see the close relationship, then divides into the middle cerebral artery and the anterior cerebral artery here, okay? This here is the chiasm right there. Okay. All right. So there are a few other structures that I want to bring your attention to. Does any of the students who's watching know what this structure right here is? This white structure right here? Any of the students on the live chat? You want to have give me a guess what this white structure is? Let's see if I can see the chat here. Pituitary stalk, very good, Sulaiman. Very nice. Okay. So this is the hypothalamus is behind us. This is a pituitary stalk. This is a pituitary gland right here below us. Okay. So we, the microsurgeons, come from the sylvian fissure this way to look into this area. The endoscopic surgeons come from the nose to come here. So that's a pituitary gland. Okay. So among the very smart people watching, what is this vessel coming of the internal carotid artery here? What are these vessels? Anybody give me a guess?
Come on, guys.
Come on now.
Yeah, in med school, there was always someone that got it right.
Yeah.
Superior hypophyseal artery.
So we all know the very good. So we all know the big arteries that come out of the carotid artery, right? So behind us here, the carotid comes in. Underneath will be the ophthalmic artery. We know well. Then we have behind us here is going to be the posterior communicating and the anterior choroidal that we know well. But the superior hypophyseal arteries are tiny arteries that come from the medial part of the carotid, go towards the pituitary in the stalk. This is the superior hypophyseal arteries. Now, their only important, really true importance from a surgical perspective is the fact that you can form what's called the superior hypophyseal aneurysm around the superior hypophyseal artery. So these superior hypophyseal aneurysms can be very tricky. They come at the origin, and now this explains to you why the superior hypophyseal aneurysms are different. They're pointing medially. Why do they point medially? Because the hypophyseal artery comes out medially. So the anatomy of the superior hypophyseal aneurysm is totally different. It's a totally different thinking about it because it's coming off here. Whereas the posterior communicating artery aneurysm will be coming this way, and the anterior choroidal aneurysm will be coming this way, and the ophthalmic aneurysm will be just underneath the optic nerve sitting here. So the location of where the origin of the original artery is, as a surgeon, gives you the anatomic understanding of what way the aneurysm is going to be pointing and what way surgically, technically, you need to deal with it, okay? So understanding this anatomy is very important, and I'm glad we're covering this, okay? So that's the superior hypophyseal artery. Very good. You guys doing a great job. Okay. All right. So this would be the sella underneath us, okay? That's the pituitary stalk. So this is our friend, the carotid artery on this side. This is our friend, the carotid artery on this side, okay? Let me ask, what are while we're at it, let's just have a good time together. What are this artery, a couple arteries coming out here from right here? What is the name of these arteries? Who's going to give me an answer?
Coming from middle cerebral artery? Or,
yeah.
Lenticulostriates.
Yeah.
Arteries.
So these are the lateral lenticulostriates, very important vessels, okay? As a surgeon, when you're coming down here, if you mess with these arteries, we're going to give the patient 100% a deficit, okay? There's no two ways about it, okay? The lenticulostriate arteries, these perforating vessels that you cannot be messing around with, okay? The reason I want to explain to you why these arteries are so sensitive, these are end arteries. So as they go here, they go straight, to the internal capsule, to the basal ganglia and everything. They don't have a lot of collateral flow like some other arteries do. So an end artery goes straight like this and it supplies the structure. Whereas a lot of these larger arteries, they have a lot of interconnections. And sometimes if there is an obstruction, you can get flow. But these arteries do not tolerate that any kind of, messing around with them. So my advice is do not ever mess around with the lenticular striates. Now, why am I saying this to you? When you're doing surgery, you are coming from the sylvian fissure, you're coming this way, right? Always stay on the lateral aspect of the middle cerebral artery. Never dissect on the medial aspect. Why? So you're coming down sylvian fissure. I see people going this way, that. No, there is no reason in the world you to be here. Okay, there's no rationale in the world for you to be operating here. So always stay on this side, never on this side of the M1. Simple rule. No, there's no indication. Okay, don't. Okay, so this is the kind of stuff that I want really the people to understand to avoid complication. Okay, so that's why I'm not making these points for anatomic reasons. Okay, I'm making them because of their impact from a surgical perspective. And that's the point I'm trying to make here. Okay, very good. All right, let's continue. All right, you guys doing a good job. All right, so they're making this easy for me. All right, let's go. Structure here, meaning okay, so how do we expose the internal carotid artery in surgery? I would like to take you through an actual surgical. Okay, now let's talk about real surgery, okay? We talked enough anatomy, now we're going to talk surgery. We're coming in from the right side through the right sylvian fissure, like we showed you, the terioneal craniotomy. That means this is our right temporal lobe. This is our right frontal lobe, okay? This space in between is our sylvian fissure. So we just went through here. Remember, we talked about the anatomy. We got the optic nerve. What does that mean? That means this is our friend, the carotid artery. Okay. Now, this patient has this thing sitting right here, which is an aneurysm. But now you know what aneurysm this is. You see, because you know the understanding, this is an ophthalmic aneurysm based on what I explained to you. It is not a hypophyseal aneurysm. Remember why? Because you know now. Hypophyseal aneurysm will be coming off on this side going that way. Now you know, okay, I understand. I know how to name it right. I know surgically how I deal with it, okay? So that's very important, okay? It's pushing on the optic nerve, all right? So that's fine. So right optic nerve, carotid artery, we continue. Cool approach to the internal carotid artery. And first, let me define for you the anatomy as we have discussing this. Okay, a couple things, technical things. I don't use retractors, which I believe personally is less traumatic to the brain, but if you use them, that's fine. I use a suction in my left hand and micro scissors in my right hand. Okay, that's all you need. You don't need expensive instruments, image guidance, crazy stuff. You don't, because you know your anatomy. Okay, so keep it that way. All right. So suction left hand on low suction, micro scissors right hand. Okay, but you could I can use both hands for everything. So depending on the situation, sometimes I'll have the scissors in my left hand, the suction in my right hand, depending what situation I'm in. And that's how I want to train you. By the way, this reminds me, during the Granada, Spain Congress coming up in September, I'm going to do a live demonstration on a cadaveric head that we will transmit around the world, where I'm going to go through all this anatomy live under a microscope. So please mark your calendars. Those of you who are not going to be in Granada, we will transmit this live to you, and we will go through all these regions in a very, in an operating room kind of a setting, where I'm going to explain all this anatomy to you in a lot of detail. So please make sure you're going to be there. Okay. Area so far. Okay. So another question coming up now. Stay awake with me, please. What is this structure over here I'm seeing? White structure. Come on, guys. These are very quick questions. I want very quick answers. Who's going to tell me real fast? Why are you guys being quiet? Are you shy?
A little shy.
No, yeah, please. Who's going to tell me what is that white structure? Madalena. I'm going to start calling names.
No, Victor, are you there?
Oh, Victor knows this stuff.
Uh,
Okay, so of course, this is our right optic nerve. That has to be our left optic nerve, right? So they come together to form the chiasm here. Right and left optic nerve. You're looking from the right side, okay? Surgical anatomy, okay? Very cool. All right, let's keep going. So this is a right-sided terional approach. That's a temporal lobe here, arachnoid carotid artery, because it is. In this case, I'm working around a arachnoid swimming in. Now I'm going to go more this way. I'll show you. Fluid in this area. And it's also known as a supraclinodal carotid because, so this portion of the carotid, we have a couple different names. This is a subarachnoid portion of the internal carotid artery, because it sits in CSF. Before this level, and you know, we can go into those classifications if you take my course, we call it different names because before this point, it's not sitting in CSF. So it's not subarachnoid space. Or we can call it the clinodal carotid because the anterior clinode is right here. We could call it the clinodal carotid. Very good. Projection of bone right here is the anterior clinode, known as the anterior. So that's our old friend, the anterior clinode. Okay. So that's what we are now. And as we look at this artery, as you watch me doing this surgery here, you will see that in my left hand. Okay, I mentioned that already. Okay. Now I'm coming, following the carotid, the optic nerve, and coming back this way. I want you to look at this. This is at the level of the proximal synovial fissure. I'm coming back this way. Okay. The only way I'm going to be able to follow the carotid artery to the bifurcation into the anterior cerebral artery and the middle cerebral artery is for me to get back here. The reason I'm doing this is you will see the vessels, you see, from the surrounding structures. So from here to here is the optic nerve. About this level is the chiasm. This is the optic tract. Okay, so that's very important. In this case, I'm working around a vein, a Sylvian vein. Be careful not to injure these veins. Very important. Okay. Now, what are we seeing? Do you see the nice thing? Not having retractors injuring the frontal lobe. I can work in the area I'm in without injuring the brain. Very smooth, very nice, okay? Without hurting anything. And as most of you know, I do all this awake. You don't have to do it awake. That's really for very experienced surgeons. But I'm also talking to the patient, make sure there is nothing happening that is concerning, okay? But as far as a dissection, the sharp dissection, all of you guys should be able to do it that way. Here, I think it's important to know. So essentially, we said that this is our optic nerve, okay? That's important also from an anatomical carotid artery on the right side. So where are we gonna get to? Okay, now we're seeing something interesting happening. All right, guys, don't be shy with me, okay? I want to ask you so you think about it. So this is a carotid artery, our friend. Now I'm seeing something interesting coming this way. What is the structure right here? Okay, guys, quick, tell me an answer, please. Who's going to tell me what that is?
It's look like A1.
Yes, So the carotid artery is coming here and it's going to bifurcate into the anterior cerebral artery going that way, and the middle cerebral artery is going to be going this way into the cerebral fissure. So that is the A1 segment of this vessel. Very nice. Okay. Let's keep going. Let's expose it. Let's expose it. We are going to get to the bifurcation. Now, the internal in this patient, there's an interesting structure here. The middle cerebral artery and the anterior cerebral artery. In this patient, we've got another aneurysm. So that's a carotid artery dividing into the anterior cerebral artery, middle cerebral artery, and there's an aneurysm sitting right here. Okay. This is the end of the carotid artery. So we call this a carotid bifurcation aneurysm. Okay, just based on the location. Carotid bifurcation aneurysm between the A1, the M1, carotid bifurcation aneurysm. Okay, so that's how we do this. Okay, in this case, we have an aneurysm right there. It's quite a complex aneurysm. You see, it's bilobed. Okay, it's got perforators. You know, it's one of these things, and that's why I've just put a temporary clip to dissect this aneurysm. Okay, so we will here show you that there is an aneurysm at the bifurcation. So let's follow the carotid artery right here, okay, and the anterior cerebral artery. So we already talked about anterior cerebral artery. This patient middle cerebral has a what we call a bilobe. You see, two lobes to this aneurysm. We will be discussing aneurysms in the next lesson, but I wanted to show you the anatomy of what, and then the beginning of. See, that's anterior cerebral artery. That's our bilobe aneurysm right here. Okay, so that's okay. So that's really the just the initial anatomy that I wanted to about the neural imaging. Okay. Of the internal carotid. Okay, let's stop here. Let me go to the next one to continue. Okay, let's go to part 2. I would like to thank Dr. Takashi. We are translating these lessons into multiple languages, and he is actually translating them into Japanese for us. He has been tremendous for us, and we really appreciate his effort. So these lessons are being translated into Spanish, Portuguese, Chinese, Japanese, Russian, so multiple languages that, especially in countries where people, medical school is not taught in English. Okay, so and I appreciate Dr. Takashi's. Okay, so let me just do one more thing. I'm going to ask a question that's not going to be an easy question, but let's ask it. Because every lesson we ask a question before you take the lesson, and then you give us, then you take the lesson and then you give answers. So the first question is, this is a lateral view of the carotid artery. Okay, what is this vessel coming out here? Okay, so you saw as we're looking at the carotid artery, we saw you come, this is where from here to here is the supracarotid portion. Clearly, this is the ophthalmic artery, okay? This cannot be the superior hypophyseal because it's going this way. The superior hypophyseal will be going this way. So this is a posterior communicating artery, okay? So that's nice. Okay, let's see this one, okay, next. Okay, now this is this question is a little bit difficult. Okay, now this is an anatomic view from below. Okay, so remember, we're looking from below the brain. So this would be our carotid artery coming in on the right side from below. And right next to it is the optic nerve that we have known around the anterior collinum. Carotid artery continues. Okay, right here. And there's this artery coming out right here. Okay. What is this artery, folks? What is this artery? Who's going to tell me the answer? Who's the brave one among you?
This one in green is the posterior communicating
That's
artery.
exactly right. It's the posterior communicating artery. I'm showing it from below. You see, that's the carotid artery. Comes here. It gives ophthalmic there, whatever, and then comes and it has this big branch from underneath the posterior communicating artery. How do you know? Well, it's supposed to, for many reasons. Posterior communicating come here. It goes around the brainstem to become the posterior cerebral artery right there. Okay. So that's the posterior communicating artery. That's very good. Okay. So let's say, is that one of the answers? Good. Okay. Good. Next. Now this is not an easy one. Okay. Let's see. Imagine you're looking at the person from the side. So this is a front. This is a back. This is the top of the head. This is the bottom. And we're looking here. Okay. So this is our internal carotid artery. Okay. That is our third cranial nerve, the oculomotor nerve. Okay. All right. This is our basilar artery. Now, I know I'm adding a lot of stuff and you have not watched these lessons, but, you know, I'm not making it easy for you, but this is not an easy one. Okay. This is a basilar artery. Okay. And it has the two PCAs here and here, P1s. Okay. That's the third cranial nerve. This is, of course, this is the midbrain. That's the thalamus. Okay. Okay. So the question is, what's the red arrow? What is the red arrow showing? So to get to that, let's continue the lesson, and we'll come back because this one is a little bit more difficult. Okay. Let's just pick a wrong answer. Fine. Okay. We got 2 out of 3. Fine. Let's go into the lesson and see what we got here. All right. So we're looking at this area again a little bit more. I will commit that once you have finished taking it, the posterior circulation, I'm going to show it to you about using the specific. Okay. So let's look at from above, a different view a little bit. Okay. Before, remember, we're going back to your old friends. We have our optic nerve. Fine. Then we have the carotid artery just below it. Remember this tiny little baby thing. We said that's a superior hypophyseal artery. We told you that the ophthalmic artery is going to be right below it, right there. And then the posterior communicating and the anterior choroidals will be coming out of the carotid as it continues. Okay, very good. Let me add another structure. This is the edge of the tentorium. Okay, edge of the tentorium. This is the third cranial nerve, number 3. Okay, that's our old friend, the pituitary gland. That's the pituitary stalk. What is this structure right here? Who's going to tell me? What is that structure? Anyone? Okay, that's a fourth cranial nerve. Okay, this space right here is the cavernous sinus. That's a whole lesson right there. Everything inside this is a cavernous sinus. Okay, so let's continue. This is actually, you can hardly see, this is 6th cranial nerve right down here. Okay, the very section, I want to point right there. Essentially, the basilar artery would be sitting right here. Okay. The basilar artery would be sitting right here against the clivus. And I'm trying to 3-dimensionally. So now what I'm trying to explain, the posterior communicating artery will come off here. The basilar artery will send P1, okay? Posterior communicating artery comes here and joins the P1. So this now becomes P2, okay? After the PCOM joins. So that is how the posterior communicating artery joins the posterior cerebral artery. So if you have an aneurysm right here, we call it a posterior communicating artery aneurysm. If you have an aneurysm here, we call it a basilar apex aneurysm. If you have an aneurysm right here, we call it a P1 aneurysm. And if you have one of these weird aneurysms back here, we call it a P2 or P3 aneurysm, okay? So just based on the location, folks. Okay. We explain as we move forward. So if we go back, let me show you an anatomic view of this, okay? So that's our carotid artery, as we've known it, posterior communicating artery right here, okay? Joining what? This is the top of the basilar artery. This is P1. And that becomes P2, okay, right there. What's underneath us is very important in relationship to this, the third cranial nerve, right there, okay? That's very important to understand the relationship. These tiny arteries are the most important arteries in the human body, most important tiny baby arteries. Does anybody know what we call these baby arteries? Somebody tell me what we name these. These are what make surgery of basilar apex aneurysms very dangerous. And someday when I get to meet you to talk about basilar apex aneurysms, we're gonna get into this. But what is the name we give to these tiny baby arteries, which I have called the most important tiny arteries in the human body? Okay, you guys are being sharp. Posterior thalamo perforators. Okay, if you occlude these arteries, the patient may never wake up. This is what can cause coma in a patient, okay? And it's a disaster. This is why this area is very, very sensitive, okay? So, okay, let's continue to the anatomic to become the anterior cerebral artery. And so let's go back to our old friend cerebral artery here, the internal carotid artery. Let's look from the side again. We went through this anatomy many times, but I want to do it again because we have some junior people here. I want to make sure they understand this anatomy very well. So this is our friend, the internal carotid artery right here, okay? We're looking from the side. We drilled what's called, we removed the anterior clinoid. Why did we remove the anterior clinoid? Because by removing the anterior clinoid, we could look deep underneath here and we're seeing our ophthalmic artery going into the orbit right there, okay? So that's our ophthalmic artery, okay? Now, this artery goes in, as we saw in the last case, becomes the anterior cerebral artery here going this way, and the middle cerebral artery going back this way, okay, towards the sylvian fissure, okay? Now, here is our posterior communicating artery going out this way, and behind this is going to be the tiny anterior choroidal artery there. So this is posterior communicating artery going behind us, okay? And as you recall, of course, that's our right optic nerve, left optic nerve, just like the anatomy we showed you in the surgical case, okay? The last case we showed you, there is an aneurysm sitting here, okay? That's very good. Just anatomically, so you understand very well, this here is the left internal carotid artery on the other side, and we're seeing it from a side view right there. We cannot see our superior hypophyseal artery because it's on the other side. So it's going to be there, the origin of it on the medial side, we cannot see. That's some of his branches. That is why we have said in the literature to expose the superior hypophyseal artery, and I wrote a comment about this, it's easier to access it from the opposite side. See here, we know where the superior hypophyseal artery, so sometimes it's easier to clip an aneurysm, a superior hypophyseal aneurysm from the contralateral side. It's easier for me to see the left superior hypophyseal than it is for me to see the right, okay? So those are important things to keep in mind in that perspective. All right, let's keep going. The tentorium. This is the area. That's the edge of the tentorium. That's the third nerve. You see how close it is to the posterior communicating artery. We talked about that. This is the cavernous sinus. The relationship is important. This region back here, behind the carotid, where the posterior communicating joins the posterior cerebral artery. That. Okay, let's do a surgery together, guys. Okay. So, as we're entering an actual surgical case, I would like to go over this with you. We are this time going in from the left side. As you know, so far, we have come from the right side. I showed you right-sided views. In this specific case, we're coming in from the left side, okay? So what is our trajectory? So essentially, we are going to, first of all, we have what's called a pterional craniotomy right here. That's our pterional craniotomy that we have talked about in our first lesson, okay? And what we are going to do is enter between the frontal and temporal lobes through the sylvian fissure right here. So that's going to be our trajectory to enter from that center. And the reason is that what we're trying to do is get again to this deep area. If you could imagine that there's a point here where the carotid artery and the optic nerves are, and then we are going to go through here, through this location here to enter that area, which is essentially what are we looking for in this specific case. Because we're looking from the left side, we're going to have our optic nerve like this, and then we're going to have our carotid artery next to it right here. Okay, so that's it's like the opposite mirror image what I showed you on the right side.
As we know that the carotid artery divides into the anterior cerebral artery and the middle cerebral artery. Now, in this specific lesson, what we're looking at and specifically looking for is the posterior communicating artery, which will be right here. And based on our orientation so far, the edge of the tentorium would be somewhere right here, and the third nerve would be somewhere right here. So that would be the view from the left side that we will be looking at. Let's now enter into an actual surgical scenario. This is a left-sided transsylvian approach. So let's orient ourselves. So this is the left frontal lobe. This is the left temporal lobe. Okay. This is our internal carotid artery here. ICA, okay. And this is our optic nerve here, becoming the optic chiasm back here. Okay, so that's oriented in this process. The carotid artery, as you know, will go on to divide into the middle cerebral artery and the anterior cerebral artery here. So that's orientation to the approach. This angle right here is the sylvian fissure. We're coming through the sylvian fissure on the left side to enter this area. Okay, so this specific case is for me to orient you to the posterior communicating artery. In this specific case, where actually I'm operating on a large tumor in the base of the skull. This is all tumor down here. But that's really not the focus of this specific demonstration. It's just I'm using it to explain to you how to handle the posterior communicating artery. So here I am. This is my left hand. I have this suction device. In the right hand, I have these micro scissors. This is the temporal lobe, the mesial part of the temporal lobe, which we call the uncus. I'm mobilizing it to get on this side of the carotid artery. And as you see, I'm cutting these arachnoid layers to expose them. So this is, now I'm zooming in a little bit more. And now we get to our friend here of what we are working on today. So essentially, this is a carotid artery here, as we said, and then it has this branch right here. Okay, that is our posterior communicating artery. Okay, so that's on the lateral side. On the lateral side, in this case, the left side, we expose the posterior communicating artery. Okay, and just as we talked about, just to get three-dimensionally our view, the edge of the tentorium would be somewhere here behind us. And the third nerve, we would be expecting it to have somewhere deeper here. So that's the anatomy that we're looking at. And let's continue to dissect in this area. So as you see, this is our posterior communicating artery right here. What you're looking here is a craniopharyngioma, a tumor embedded deep in here. So I'm now dissecting in front of the PCOM to get into this area right there. Okay, so this is just to give you an appreciation of what we have. Let me show you one more thing. Now, we've talked about how the posterior communicating artery connects with the posterior cerebral artery. So right here behind us is the basilar artery, okay? And just we see behind the tumor here, okay? Now, we talked about how the basilar artery comes up. Now this would be behind us, we're not seeing it. It would have this, its final branch, which is going to be the posterior cerebral artery, okay? And so we talked about how the posterior communicating artery is gonna go and connect to this artery there. And that's gonna happen all behind us here. I'm just trying to give you the three-dimensional view of how we see this and where we expect things to happen. So here it is. That's our posterior communicating artery here. And now we're dissecting in front of the posterior communicating artery to get into this deeper area. Essentially, we are now in the posterior fossa, in front of the brainstem and in front of the basilar artery. Now, I would like to show you. We talked about this. Let me just finish with this. Yeah, this brings us to the final thing that I want to talk about. To another cadaveric view of the. So this is very complicated, but it puts everything together for us, and I'm going to end it with this. This is a question I asked early on. So this is a front. This is, we're looking at the left side. This is a front. This is a back. This is the top of the head. This is a bottom. Okay. So let's follow what we know. Internal carotid artery coming in. Okay. We're not seeing the front part, the anterior clinoid and everything else. Okay. And it continues. Okay. And actually what we're seeing here, this is going inside the sylvian fissure to be a middle cerebral artery. Okay. This is the thalamus. This is a midbrain. This is a pons. Okay. This is a basilar artery. Okay. And it's
branches right here, the two posterior cerebral arteries. Okay. So this question I asked early on, and this is the third nerve here. What is this artery? That's our friend, the posterior communicating artery. See, right there. That's our friend, the posterior. You see, if you really follow it, it is connecting with the P1 here, right there. Okay. So it's a difficult question, but it is the posterior communicating artery. Okay. So this becomes the posterior cerebral artery here. All right. Difficult anatomy, but we went through all the principles together. This is really why we created this University of Neurosurgery. When I was a resident, it took me a couple of years to understand all this stuff because there's no book that explains this. So, you know, I ultimately, we created this to make it easier for people to understand the surgical anatomy of these things. All right. So it's been a pleasure to be with you guys here. I think that's about all we're going to cover today. I mean, we could go for hours with this kind of thing, but I think this was the orientation that we wanted to do from my perspective. Okay, so let's stop share here. All right, so if there are any questions for me, I'm happy to take them, but I know we have other speakers here. Okay. Hopefully with time, I will spend time with all of you guys in really taking you through this kind of understanding of the surgical anatomy. Plus, as I said, in September, I'm going to do a live dissection that all of you can watch, even if you're not in Spain, under the microscope, where I'm going to go through all this anatomy, all these vessels, all the skull base anatomy in one session. I'm going to go through with you very systematic way, all the surgical anatomy of this area in September, and we will make announcements, of course, about that. So it's been a pleasure to be here, and I want to respect the other speakers. You know, I think I will stop here. Ahmed and Dr. Takashi, if there are any questions that people have about anything I said, I'm happy, you know, happy to answer anything.
Okay, so I'm Takashi Kon from Tokyo, Japan, translating your English to Japanese. So very informative and very basic anatomy is very understandable. So that's good for education for residents or students. So we are eager to translate and go further. Then the basic anatomy is very important, and very important that the picture and cadaver and a picture is very good picture, very easy to understand. So we continue to work for translation. Thank you.
Thank you. Thank you, Dr. Takashi, what you're doing by translating this for our students and residents and junior neurosurgeons in Japan. We're really transmitting knowledge in a way that I think is important. So your work in translation to Japanese, these lessons, is really, really important. So I really thank you for your effort. You have been tremendous. Dr. Manuel has his hand up. I just want to make sure we recognize him.
Yes, hello, Professor Salem.
Hello.
Nice presentation. Thank you. Thank you to all. John, everybody, Victor. Two questions for you. First is when you come to Moscow, gonna be very nice to have you here.
Yes, yeah, I was just 2 weeks ago with Professor Konovalov, and you know you know, he is somebody we respect. You know, we have. You know, these giants who have contributed so much, we respect them, and he is somebody I respect quite a bit, and the team at the institute there. So hopefully within this coming year, I will be coming to Moscow and St. Petersburg. So we will keep you updated for sure.
Excellent. And the second one is, who is translating in Spanish your lectures?
Yeah, we have a number of people, a team. If you want to text me or Dr. Takashi, we can introduce you to them. We have a team that's doing the translation. If you want to help with that, we welcome you. So please either send me a message or Dr. Takashi. He's part of a very global team that's doing the translation to multiple languages.
Amazing, amazing. Thank you. Thank you so much.
So, of course. Any other issues, questions, concerns? I want to respect the time of the other speakers, so I just want to be respectful here.
Yeah, thanks, William. We'll have better interaction in the future.
Thank you.
Once
Thank
everyone
you.
gets used to it.
Great. I recognize Professor Hisham Bassouni from Germany, who's with us here as well. And he's, of course, one of the senior speakers, and he'll be speaking with you.
Hello, everybody.
Hisham, I'm sorry, because my flight got canceled overnight from DC, my meetings got condensed, so I do have to leave. And I just want to recognize you and the amazing work that you do. And I appreciate of being on this session with you, please.
Thank you very much.
Thanks for your time.
Thank you. Thank you.
Thank you, Professor.
Thank you. Bye-bye.
Okay, Ahmed.
Yeah, first of all, let me welcome Professor Hisham Bassouni from Germany. I don't know if he will present his lecture now or later.
I can present it as you wish.
Okay. You know, Professor Hisham Bassouni is the director in neurosurgical department at Clinicum at Germany. I don't know what is the name of the hospital.
Amberg and Weiden, two clinics in Bavaria, northern Bavaria, Germany.
Okay, you are welcome, Professor. You can go ahead.
Okay. I'm sorry for my voice. It has changed a bit. I'm a bit ill, so but it's a great pleasure to join this webinar. So. I hope you can see my screen.
Yes, want to make a bigger presentation?
Like this?
There you go, perfect.
And hear me well?
Yeah, of course.
Okay. So my topic today is about microsurgery of anterior cranial fossa, meningiomas, and particularly olfactory groove meningiomas. And I give you my personal perspective to this topic. So just for an overview, meningiomas, as you know, are constituting the most frequent primary brain tumors, up to 25%. So 1/4 of all primary brain tumors are meningiomas. There are different figures in the literature, but this is a good middle figure to remember. Skull-based meningiomas comprise around 20 to 30% of all intracranial meningiomas, and there's the incidence of skull-based meningiomas is about 2 in 100,000 population per year. Most of the skull-based meningiomas are located in the anterior and middle cranial fossa. The least ones are in the posterior cranial fossa. You know, the olfactory groove and also the sphenoid wing meningiomas are constituting the greatest portion of the skull-based meningiomas. Olfactory groove meningiomas located here, centered around the cribriform fossa, constitute around 10 to 15%. And of course, most of these tumors are not restricted to the cribriform plate. When they become larger, they also will extend to the planum sphenoidale. So these are actually, I would consider both are one unit with different extensions. By the way, sphenoid wing meningiomas are the most frequent skull-based meningiomas, constituting around 20%. So what is the treatment goal of these tumors? And I have to give credit to my skull-based mentor, Professor Osama Al-Mefki, who I think there's no presentation where he does not stress this point to get a complete resection. This includes the involved dura and bone at the first surgery, and that's very important. But because every resurgery will be more difficult. and you have got not the planes which you got in the first surgery. And of course, this should be achieved with the preservation of function, amelioration of the patient's condition, and at least keeping the life quality as it was before surgery or even getting better. It is very important to notice that the ionizing radiation like gamma knife or linear or any kind of radiation is the environmental risk factor most strongly associated with meningiomas, de novo meningiomas, and as you know from the literature also malignant progression of meningiomas. So you should avoid radiation in grades 1, which are most of the skull-based meningiomas, and also I would also avoid it in grades 2 in the atypical meningiomas. So a historical view, the first successful resection of an olfactory groove meningioma was performed by the Italian surgeon and also politician Francesco Durante in 1885 by a left frontal craniotomy. So this was the unilateral approach to these meningiomas, were the first approaches to olfactory groove meningiomas. You can see here another historical image from Peter Krause, who was a German neurosurgical pioneer, and from his book about the experiences he got for removal of these tumors. And you see also a unilateral approach. And by the way, also at these times, the bone was also left with the flap. It was not taken away. This is a subfrontal approach to these meningiomas. So what is the surgical anatomy and the structures in danger during this surgery? First, you got the nervous structures, which is of course and obviously the frontal lobes, the optic nerves you can see here with the optic bulb, with the olfactory bulb and the tracts, and the optic nerves which you can see here, which are on the back side of the tumor. Then the vascular structures you can see here are the anterior cerebral arteries, particularly the A1 and A2, and the anterior communicant complex. And also you have to take care about the ophthalmic artery, which was beautifully demonstrated by Salim in his presentation. And you have to take care about not to injure these structures. And you, of course, nowadays, we are not performing angiography routinely, but so this is a bit an old picture, but very informative, because it shows you that the main vascular supply from the skull base of these tumors are coming from the anterior and posterior ethmoidal arteries, which are branches of the ophthalmic artery. And of course, you have to remember also that in large tumors, particularly in large tumors, there's also a significant peel vascularization of these tumors. Other structures which are nevertheless important are the sinuses, the frontal sinus particularly, the cribriform plate, and of course also the ethmoidal air cells. You have to consider anatomical variants. For example, a huge aeration of the frontal sinus, and also a very thick bone. Both of these patients had olfactory groove meningiomas, and you have to deal with these anatomical variants. So what types of approaches we've got? You've got the bifrontal, subfrontal approach with or without orbital osteotomy. You've got the frontal lateral approach, as I've already shown you, with a modern variant of mini craniotomy, the supraorbital keyhole approach, and you've got the pteronal approach from posterolateral. Further, you've got the bifrontal interhemispheric approach, that's to say without opening of the frontal sinus, and you've got, of course, the extended endoscopic endonasal approaches. So what is my personal preference, which I'm using in most of these tumors? These are the anterior midline approaches, either bifrontal subfrontal or bifrontal interhemispheric, mostly bifrontal subfrontal. And in posterior located, particularly planum sphenoidale meningiomas and of course planum and tuberculum cell meningiomas, I'm using the pteronal approach mainly. What is the reason for this preference? Usually these tumors are, by definition, midline, so they are usually bilateral. Maybe, of course, they can extend one side or the other, but usually they extend on both sides. When diagnosed, these tumors are often large or even giant. And you will see, if you're doing surgery a lot of on these tumors, you will regularly see that they have got an en plaque growth on the anterior cranial fossa. So they are not restricted to the main tumoral bulk, but you will see scattered islands of tumors around the anterior cranial fossa. And that's a very important point. You've got a very good overview on the whole frontal base. You can directly address the hyperostosis and therefore also the vascularization of the tumor at the beginning of the surgery. You have a very good overview on the cribriform plate and the olfactory groove and the bulb and the nerves, and you can protect them and preserve them if olfaction is an issue to be protected and preserved. And you've got a very good view on both optic nerves and chiasm and the optic canals, and you can also open the optic canals via this approach. A very important point, which is not often mentioned in this topic, is the anatomy of the cribriform plate. The cribriform plate may be very deep, and especially anteriorly. It flattens down going posteriorly, but it can be as deep as 1.5 centimeters or more in the anterior parts. So that's very important. If you want to remove these tumors completely, you have to get an overview in this part of the anterior scalp. And often these tumors, especially when they're growing larger, they enter the optic canals. So you have to deal also with tumor parts going into the optic canals. And these parts of the tumors may not be seen on preoperative, even high resolution MRI, but they can be seen intraoperatively and you have to search for. And of course, this approach provides a large periosteal flap to cover the anterior skull base and to seal any frontal sinus and parts to prevent a CSF leak. There are drawbacks of this approach. The first one is that you usually open the frontal sinus, performing cranialization of the frontal sinus. And there's this danger, if you do not remove the mucosa well, then there's a danger to get a late mucosal. And also some important structures like the optic nerves, chiasm, and the vessels are on the back side of the tumor when you're coming in front. So there's a late observation of these important structures. So these are drawbacks. So to give you some examples, This is a 51-year-old woman with a large frontal skull-base meningioma. You can see it here on the preoperative CT scan with calcification, intratumoral calcification. And the patient was presenting, and this is actually rare in Germany at least, with blindness on the right side. Usually the patients are coming before this, but she actually was almost blind on the right side. You see this hyperostosis here on the frontal base. And this is the tumor. You see this hyperostosis here. The tumor encroaching on the cellular area. And you can see that in this hyperostosis, there's a viable tumor. So you have to remove these tumor parts in order to get a complete removal of the tumor and prevent recurrence. And also you can see that this tumor enters more on the right side, on the, where there's blindness, but also on the left side, it enters the optic canals bilaterally. So this is the sketch from the surgery. You see here the left optic nerve. The tumor was merely compressing the left optic nerve. So it looks fine. This is the hyperostosis. You have to remove it completely. This is usually done by a diamond drill. There is a large hyperostosis, 6 millimeters or 4 millimeters. And this is the right optic nerve. You can see it is more involved in the tumor. There's still a plane to dissect the tumor from the optic nerve, from the right optic nerve, but you see that it is compressed, and also the vascularization of the optic nerve is not as it was on the left side. You can see here that it is intended and not looking good. The vessels were closely involved and partly engulfed into the tumor. You have to be very careful to dissect the tumor from the vessels. This is the anterior cerebral artery. Not to injure these vessels in order to prevent any ischemia postoperatively. So here's the both optic nerves, the chiasm, the lamina terminalis, and you see here a tumor remnant which has to be removed. And you see here the communicating artery. And after removing, you see the pituitary stalk and the back, which is usually protected by arachnoids. So you are not going to enter its integrity. This opening of the optic canal, just showing on one side. On the right side, here you can see this is tumor entering, and this has to be removed in order to have a complete tumor resection. So this is an MRI after tumor resection, showing a complete tumor removal. Also, this hyperostosis was removed here. And this is the patient 6 months after surgery. She was doing well, no deficit. So this is the vision follow-up. This was preoperatively. And this is 2 months after surgery. So there was, regaining vision. And this was 6 months, almost complete vision on the right side. So it's a good functional result after being almost blind. So this is the left side. Also, there was amelioration of vision after 6 months. So this is another example. So I'm showing you different examples with different approaches, but also some more information which I think are very important. This is a 65-year-old woman. She had weight gain, muscle twitching in the face, neck, and right arm, which are not related to the tumor, I thought, at least. But on clinical examination, there was right anosmia and left hyposmia. Otherwise, the examination was unremarkable. And you see this tumor here, which is restricted to the midline. And you can say, okay, it is very suitable for an endoscopic approach. You can remove this tumor. It even shows a narrow base. And this is the backside of the tumor, so restricted to the midline. So this, one can say, would be ideal for an endoscopic endonasal approach. You can see also in this the anatomy that there are very deep olfactory grooves, so it would be very difficult if you do a frontal lateral approach to go dip into this groove. It is you can see it using an endoscope, for example, but you cannot work on this valleys, deep valleys, anatomical valleys. You can see in the MRI that on the right side, where she had complete anosmia, there is completely filled with tumor, the olfactory groove, but you can identify the olfactory nerve on the left side. So if you want to preserve smelling and tasting, so it is important that you keep this nerve intact, which is not possible, by the way, from the endoscopic endonasal approach. So this is positioning of the patient. I performed a frontal interhemispheric, bifrontal interhemispheric approach on this patient without opening the frontal sinus. So this is sectioning of the anterior end of the falx. The tumor was a soft one. Partly suctionable. This is the olfactory nerve on the left side. Was merely compressed by the tumor, but not, it could be dissected from the tumor. So here it is. And this was the one on the right side. You see it was integrated into the tumor, as usual, compressed and dislocated laterally, but this could not be preserved, especially if you want to remove the tumor in the bulb, olfactory bulb area, which is here. So you cannot remove it. You can preserve this olfactory nerve. These are the vessels. You have to take care not to injure them. And now this is very interesting. This is the optic nerve. You can see this is tumor. These are tumor islands here in the optic canal. So these were not visible in the MRI, in the preoperative MRI. And this surely would have been missed by any endoscopic approach. But it's very important because a recurrence in this area, it is a strategic area, would affect vision. So this is the view. This is then sealing of the frontal base in order to prevent a CSF leak. Also, I got a nice periosteal flap to seal the frontal base. So this is the approach. It is above the frontal sinus, not disturbing its integrity, bifrontal approach. And this is the MRI postoperatively, showing a complete, interestingly, which I did not expect actually, was a cessation of the muscle twitching. And she had osmia. She could smell after surgery, so it was not changed in comparison to before surgery. So osmation was preserved. And this is the the cosmetic result, it is quite reasonable. This is another patient, a 40-year-old woman. She had 2 tumors, which were incidental findings, but both showed growth. This is a small sphenoid ring meningioma, but within 1 year, it showed growth, and also a small olfactory groove meningioma here, which also grew in this 1 year. And she decided to have these tumors removed. So in this case, of course, I use pteronal approach, mainly focusing, of course, on the sphenoid ring meningioma, but also removing this olfactory groove meningioma, which I show here. So this is the olfactory nerve. And this is tumor beneath the olfactory nerve and the gyrus rectus. And yeah, denaturation of the frontal base for this tumor. So this is the postoperative MRI showing complete removal of both tumors. And what is interesting is that this patient actually, I did not ask her because I would not have expected it. She said, is it possible that also my olfaction became better? So I think it was due to this pressure of this small olfactory groove meningioma. This is another example which shows you that you have to be flexible in planning your approaches. This is a 71-year-old woman with giant anterior skull base meningioma. She had severe mental disturbance. They actually came back from holiday, and she did crazy things in the holiday, and her husband took her to the hospital because this was not the usual case with his wife. And she also had pituitary insufficiency. And this can be explained by an extension of the tumor into the pituitary fossa. So this actually, it looks like 2 tumors which are kissing here, but yeah, it was one main bulk. You see this, there's a difference in enhancement, but it was one large tumor mass intraoperatively. And this patient, I did a combined bifrontal, subfrontal, interhemispheric, and pteronal approach to get this tumor removed. So these are the postoperative MRIs, and this is the patient 6 days after surgery. And she already had amelioration of the mental function, but which took several months to become almost normal as before disease. This is another example, a 72-year-old man who had a syncope, which was probably unrelated to the tumor. And so this tumor was an incidental finding. The only specific symptom was a right-sided hyposmia, and this is the MRI. So in this tumor, I chose right supra-orbital mini craniotomy. You can see it here, the steps. I'm using an incision in the eyebrow, not above and not palpebral. And incising the temporal muscle at the anterior end of the superior temporal line. You can see it here behind the orbital pillar. Here the dura was already opened. It was very sticky to the bone, and then getting a small bone flap, you can see here. Then checking if there has been any opening of the frontal sinus, which is very important. You have to address this during the surgery. And then getting off the any irregularities of the frontal, also to have a good view on the tumor and the tumor base. And then detaching the tumor from the frontal base. And this is the optic nerve. You can see the protecting arachnoid membranes. You have to keep them as far as possible intact. Debulking of the tumor, it was not possible to get it out en bloc. So now it's after reduction in volume, it was possible. So this is the optic nerve. You can also see that here are tumor islands which had to be treated. They have to be at least coagulated, denaturated, and I checked in the optic canal, but did not find any tumor. You can open it, of course, but I didn't do it in this patient. And this is an endoscopic view. You can see here the optic nerve. On the right side, this is the left optic nerve. Chiasma would be here. And this is the planum sphenoidale. This is the olfactory nerve on the right side. Was protected. This is going into the bulb and the fossa. And then you have to cover, of course, do duroplasty, and this is the opening of the bone, which is 2.5 per 1.5 centimeters. It's skin closure. So this is removal of the tumor completely, as you can see here. And this is the mini craniotomy, 3D CT reconstruction. And this is the patient after surgery. You cannot, almost cannot see this, the incision. So it is a good cosmetic result. Interestingly, this tumor was a grade 2. It was an atypical meningioma. So is there an age limit? I would say you have, it depends on the patient. I'll show you 2 cases quick in patients 80 and above. This was an 80-year-old woman with an epileptic fit, a mental disturbance. And this is a preoperative MRI and postoperative MRI, large tumor removed. And this is the patient after surgery, and she had no postoperative deficits and regained full life quality. This is another patient, 82-year-old man who had a large edema, who had presented with decreased consciousness and was suspected to have a stroke. And this is the postoperative MRI and tumor removal. Complete tumor removal in this patient was also possible, and this is the patient after surgery also regained full life quality, and he had a torticollis since 30 years ago, so this was present pre-op. What about complications? Complications do happen, and but I would say they can almost all can be prevented. So I will show you one of the complications. A 65-year-old woman, she presented with mental slowing over months, and she had this quite curious tumor with a large edema, and yeah, the edema was extensive in this patient. And now, during resection of the tumor, I pulled on parts of the tumor, and there was an arterial tear here. So it took me actually a long time. I think it were hours. I felt it as it were days during surgery to get this arterial bleeding stopped, but finally I succeeded by putting a clip on the tiny tearing artery. And this is the patient CT, angio-CT after surgery. Of course, you have to control it by angio-CT in order to have also to see if there is not any pseudoaneurysm development in these cases. So this is after reimplantation of the bone 2 months after surgery. This is the postoperative MRI. Tumor was removed. And fortunately, also the patient had no neurological deficits and made a complete recovery. So in summary, and my take-home messages for you is, I think I have demonstrated that meningiomas of the anterior skull base have often an on-plaque growth and remote tumor islands beside and beyond the main tumor bulk. And there's often also an encroachment into the optic canals, particularly in larger tumors. So I think these aspects are more the rule than they are the exceptions, even if they are not visible on preoperative MRI. What are the implications of these observations? I think that an overview is always more favorable than an underview if you're going from the endoscopic view in regard to complete tumor resection and recurrence prevention. And I think careful bilateral inspection of the optic canal should be particularly in large tumors, in these procedures. In approach, these tumors look uniform. They are in the olfactory group of Canum sphenoidale, but nonetheless, the approach should be individualized, and it should consider the tumor factors like the extent of the tumor, site of the hyperostosis, which should be removed, clinical aspects, if there's still smelling ability, and which should be preserved. It is a very important aspect to preserve smelling, very important for life quality. And I have shown some anatomical factors like depth of the cribriform plate, the frontal sinus, the thickness of the frontal bone. All these have to be taken into consideration in this surgery. And of course, as I told you, that complications are generally preventable. The example I showed you, don't pull on tumor parts in order to avoid risk of arterial tear. Always keep in mind that these tumors, especially if they are large, they have a peel vascularization also, and vessels are going into the tumor, particularly on the posterior circumference. CSF leak can also be prevented by good sealing of the anterior cranial fossa. So thank you very much.
Thank you, Professor, for great presentation. Now, if there is interpretation or question, you can ask Professor.
Yeah, I'm ready for answering you.
Okay, there's someone raised his hand.
I see.
Dr. Gibran, you can talk.
Excuse me?
You see in the chat, someone raised their hand.
Yeah, it's me.
Go ahead.
Okay, Dr. Hisham, how are you?
Thank you very much. I hope you're fine. Thank you very much.
It was a nice lecture, and I want to ask you if there is CSF leaks after operation or not.
If there is,
yeah,
you should prevent them. It is not, you know, if you are doing a large surgery and you are getting the tumor out and remove it, and this is generally spoken for all skull-base meningiomas, also in the posterior fossa, you have to take the time to seal the skull base. You have to take your time, and you have to take every measure to prevent CSF leak. It can happen, and it happened to me, as far as I remember, not in the anterior skull base, but in the posterior skull base. It happens, especially in the larger petrosal approaches. But you can, I believe you can always prevent it. So it is actually, I would be very strict and say it is a surgical failure if CSF leak happens. Of course, the larger the opening, the more will be the incidence of CSF leak. And this is actually what we're seeing in the endoscopic and the nasal approaches, which are doing a large opening of the anterior skull base. And consequently, there's also higher incidence of CSF leak. So you have to address these, any opening, and to look very carefully if there's any opening of the frontal sinus, for example, if there is any descent in the cribriform plate. Tumors are usually not going into the nasal cavity primarily, but in recurrences they do. So you have to address, and you have to cover and make every measure to cover these the skull base very well.
And
So it is a
perform
preventable complication. Okay.
Did you perform, lumbar drain, before operation or not?
No, I never perform lumbar drainage, because I think, and also if you recognize, I'm not using retractors in these surgeries, because CSF is your best friend. So if you are patient and you're let the CSF go out, you are getting a relaxation of the intracranial conditions, and you can continue without pressure on the nerve structures. I'm not using lumbar drainage.
Thank you so much.
With pleasure.
Hello, Professor Basiuni.
Hello, Victor.
Victor Hugo from Mexico City. When you are resecting anterior meningiomas, do you used to go to the anterior ethmoidal artery? Because this artery is most of the times irrigating the tumor, this kind of tumor. And once you coagulate these small arteries, anterior ethmoidal artery, you can resect with very good advantage this kind of tumors.
Yes, this is, of course, I know you're an expert in anatomy. So, it's why I prefer these approaches. You have got a very good overview on the anterior skull base, and I always approach these tumors basically, so along the anterior cranial fossa. Actually, I'm not using often the interhemispheric approach, because then you are late getting into the main vascular supply. But my main approach is detaching the tumor from the skull base, and also with coagulation of the main vascular supply. So this is the main vascular supply coming from the skull base. And that's why I also like these approaches, particularly in the very large tumors, where I know that they have quite heavily vascularized. And I've shown you the DSA. We're not performing it anymore routinely before surgery, but you can very well see the ethmoidal or the even hypertrophied ethmoidal arteries in vascularization of these tumors. But always you have to remind or remember also that, especially in large tumors, there's also a significant peel vascularization, and so that's a problem if you are tired and you want to get the tumor out, and you are pulling on parts of the tumors, particularly on the posterior circumference. It can happen what I showed you as a complication. You can tear artery, and this will take you longer, and it is not a good complication. Any complication is bad, but it's very annoying.
Thank you, Professor Basuni.
With pleasure. I think Ayman Bayas.
Yes. Thank you, Professor Hisham. Thank you very much for your nice lecture. My question about the first question is about what about the angry brain? Or I mean the frontal edema. Do you hesitate when you see a edema? You consider that you may have a swelling brain? I saw that you show us one case with remarkable edema, and you proceed with the procedure. My other question, please. Can you hear me well, Professor Hisham?
I can hear you. Continue.
Yes. About the reconstruction of the skull base and the frontal, do you use mini plate? Do you use stitch, or do you use another something else? If you can light us, please.
So to the first part of your question about the angry brain, actually, it is an unfortunate nomenclature to say it's angry brain. You have to, in these large edemas, you have to be very careful with the brain, as always in all the intracranial procedures. But you should not. It's my belief, particularly in these large edemas, you should not use retractors, because if you talk about an angry brain, it will get more angry if you use retractors. So don't make it more angry, or don't make it more swollen. Actually, I've shown two cases, the one where the complication happened, and the one also the old man, 82-year-old man with a very huge edema. I'm not using also retraction in these patients because actually the tumor is giving you the space, and this edema will not lead to a closure of this space the tumor gives you, even in edema of the brain. So you can continue with the surgery and remove the tumor and use just your bipolar and suction and decompress the brain, and it will not disturb you actually. Of course, there are differences in brains which are very relaxed, where there's no edema, and very edematous brains, but actually can continue. So the second part of your question, I'm not using mini plates routinely. If there is, I'm even larger defects of the anterior skull base, I cover it with periosteum, which is a perfect material, not yet reached by any artificial or industrial product. It is a great material to cover the brain and the skull base. Sorry, so I'm not using mini plates. Of course, mini plates for reconstruction or putting back the bone, I'm using either mini plates or craniophix, one of these materials, but not for the skull base.
Thank you, Professor. Thank you for your answer. Thank you so much. Please, about the edema, do you use any medication pre-operative? Do you prepare the patient with dexamethasone or anti-epileptic drugs or something like this? Or, I mean, pre-operatively with those large edema, do you use any medication pre-operative?
Yes, and I'm using dexamethasone, and it's good to pre-treat the patient for some days with dexamethasone. I'm not using anti-epileptic drugs prophylactically, because it is not proven that they will be of any benefit if there was no epileptic fit already. And I'm also not using antibiotic prophylactically, just a single shot during surgery, and that's all.
Thank you so much. Thank you.
Thank you. So, John, it's your turn, or Ahmed.
Okay, Professor. Okay. Now I'm gonna give mic to my colleague, Madalina from Romania. You can go ahead, Madalina.
Hello, everyone, and thank you so much, Professor Bassioni, for this engaging and interesting lecture, and also Professor Abdurrauf for the one before you. Both amazing presentations, helping us students understand much better the neuroanatomy and the neurosurgery. My name is Madalina Popescu. I'm the president of Dandy Romania. And please allow me to congratulate Ahmed from Dandy Yemen and Nicole from Dandy Bolivia for this amazing event and their hard work for making this all happen. And I would also like to address special thanks to Dr. John Bennett and Neurosurgical TV for their continuous support for our Dandy clubs and their implication. And thank you for making such events known worldwide. Without going any further, it is my greatest pleasure and honor to introduce to you the next speaker, Professor Adnan Alawadi, President of Yemen Neurosurgeons Chapter and member of World Federation of Neurosurgery Societies. Professor, whenever you want, you may start your presentation.
Hi, everyone. Nice to meet you with this presentation. Thank you for Dr. Salim Abdurraif and Dr. Bassioni for their nice presentation. My lecture is, will go fast for the lecture. You see everyone?
Yeah, perfect.
Okay. Now let's start my case presentation about the traumatic CSF flake. This is a very noisy topic for CSF flake after trauma and taking a bad decision about to operate or not to operate a patient in a traumatic case. First, we will discuss the basic anatomy, which was described by Dr. Salim Abdurrauf before and Dr. Bassioni. You know that frontal skull base is from the frontal bone up to the posterior clenoidal. So we cerebriform plate and the frontal air sinus. And this is the opening of the frontal air sinus with the ethmoidal air cells also behind, below the frontal skull base. This is the view of the anterior skull base, the cerebriform plate and the fimbria for the olfactory nerves. This is the clenoidal process. This is also an anatomic base for the frontal bone, ethmoidal bone, nasal bone, and this is the maxillary bone. This is the coronal plane, show you the frontal base. This is nasal cavity. This is the ethmoidal, and this is the maxillary sinus. For the breast skull fracture, we have generally classified it as a simple or a compound breast fracture, with depending upon breaching of the galea and the skin or up to the galea. If the skin is not, or the skin breach is not involving the galea, it's will a simple cranial debris fracture. But if it's involved the galea and go forward to the deep laceration, we compose it as, or we call it as a compound debris cranial fracture. Now we have one case. We'll describe what is the best ideal work for management of a debris skull fracture, either to operate or not to operate. For a debris skull fracture, the indication for operation is simple. If you have a debris skull fracture which displays more than 1 centimeter or more than the half of the thickness of the skull, or is a contaminated, very contaminated, you have indication for operation. Or if there is an involvement of the air sinuses, cosmetic disfiguring, or there is an indication for an underlying hematoma or pathology that you need to operate, you should operate and not hesitating for this kind of trauma. In our case, we have for involving the frontal air sinus, we have to describe if there is the anterior turbinates displaced or not, if there is fracture evidence of the nasofrontal outflow obstruction of the nasal sinus duct. If there is an obstruction for these nasal ducts, you will see accumulation of the mucus secretion, which will enlarge and make mucocele, which is a risk for infection and mass compression for the brain. If there is a displacement of the posterior tablet greater than the thickness of the skull, because this is predictable likely for laceration, presence of refractory CSF flake, all these features are indication for operation of the debris fracture over the frontal air sinus. What we will do for this kind of fracture? Either we will do simple reconstruction involving the either in situ elevation and plating, or we have to do either obliteration procedure or cranialization procedure. The difference is that in obliteration, we should close the sinonasal duct either with fat graft, but with cranialization, we should cover the cranial cavity, the sinus cavity, and isolate it from the brain by putting either a fasciolata or the pericranial flap over the frontal air sinus to isolate it from the brain. In this kind of procedure, you have to remove all instruments you have used in obliteration or canalization of the frontal air sinus from the procedure, because it will be considered as unsterile after this procedure, and you should use another instrumentation to process further. What are the indications for CSF fistula surgical treatment? You know that the conservative treatment for CSF flake, we have to consider the duration of the conservative treatment, the type of the fracture. If there is lake, if you have already done make a patient to rest, give him acetazolamide, try to do lumbar drain, and to exclude the presence of pneumocephalus in the presence of CSF flake. That should it may be dangerous to develop the herniation or tension pneumocephalus in the presence of lumbar drain. Development of meningitis. If there is meningitis, you will consider directly for surgical treatment. If there is a CSF trap or there is a mucocele or underlying pathology that indication for operation. Another indication for operation is the severe anterior scalpus defect, evidenced by CT scan or endoscopic that the brain is externally herniated through the skull defect. What are the surgical techniques? We'll discuss it in that from the beginning in the position of the patient, in the supine position, myofield declamp, scanation to be a bicoronal, craniotomy, a bifrontal with preservation of the precranial flap as a single layer. We will give you an example for the rest of the procedure. What we'll do after that, we will do cranioalization of the frontal air sinus, mucocele removal by monopolar coagulation, fat graft, and gill form soaked with iodine. Then we'll stitch the pericranium to the dura and opening the dura and reconstruction. Then the anterior skull base defect, and we will close the procedure by subdural drain, epidural drain, sorry, and bone fixed in position, and the incision closed in patient layer. In our case, it's a 30-male patient, post-RTA with open compound frontal bone fracture involving the anterior and posterior wall of the frontal air sinus, fracture of the frontal base bone. Patient had a CC flake from the first day of trauma, treated by simple skin debridement and suturing in Countryside Health Center. 1 month later, he presented with a severe headache, neck rigidity, and fever with continuous CC flake. Controlled brain CT scan showing pneumocephalus, big frontal mucocele. Patient treated for meningitis in ICU, then prepared for surgical repair of the skull base fracture and frontal air sinus cranioalization. This is directly post-trauma brain CT scan, show fracture in the frontal base bone. There is hematoma in the nasal cavity. You will see here fracture in both anterior and posterior wall of the frontal air sinus, and also in the supraorbital ridge. And you will see a small amount of pneumocephalus here that indicating this is the dura is injured. This is the CT scan directly post-trauma. Patient already treated only by skin closure. We are reviewing the CT scan in the first day of trauma. There is a big indication for direct repair of the frontal air sinus. The fracture line is involving both anterior and posterior wall of the frontal air sinus. There is CC plaque. There is a pneumocephalus. All these parameters are indication for direct operation and not for just a simple skin closure. For that reason, the patient, after 1 month, developed this picture. He came with a continuous CC plaque, a big mucocele. There is a pneumocephalus all around the brain. Here's the 3D we will show you in more detail. So this is the frontal base. Okay. This is still opening or fracture of the anterior and posterior frontal air sinus. This pneumocephalus and mucocele. This is a sagittal plane. So there is a defect in the skull base. This is a 3D. Show the supraorbital fracture and the nasal bone cavity fracture. The frontal air sinus fracture. You have a coronal view. This is the coronal view showing this is the mucocele connected with the nasal cavity due to some obliteration of the sinonasal duct, which lead to this picture of big mucocele, which made a mass effect on the frontal brain tissue. Patient was admitted to ICU, and routine investigation was done, treated as a case of meningitis, and prepared for frontal skull base repair. And all the routine investigation was done. A brain CT scan without contrast, cysternography was not done. Medical fitness and the written consent was taken. This is the preoperative CT scan after treatment for pneumocephalus and meningitis. Show a big mucocele, but still there is the patient complaining of a CSF flake. What is our surgical technique? In a general anesthesia and supine position with head fixed in my field frame and the right side prepared for a facial autograft, antibiotic given as a start and continued for 1 week post-operative. Skin incision is a bicoronal incision, 1 centimeter in front of the target of the hair to the other side, from the right to left. And craniotomy was done for bifrontal craniotomy. This is the precranial flap we should preserve to use for reconstruction or for cranialization of the skull base. We dissected as a single piece for reconstruction of the skull base and for cranialization of the frontal air sinus. This is the craniotomy figure, a borehole, done keyhole, and then bifrontal craniotomy as a single piece. Then we do obliteration and cranialization of the frontal air sinus first by removal of the mucous membrane of the frontal air sinus and soaked with the, covered with the fat which was taken from the thigh and with dual form soaked in iodine. Then the pericranial flap was covered and sutured to the anterior wall of the dura for cranialization process and isolate the frontal air sinus from the field of the anterior frontal base for reconstruction. Then the dura was opened and the frontal air and the frontal anterior frontal skull base was reconstructed by the same maneuver as we do for cranialization of the frontal air sinus. We do it for the ethmoidal and the cerebral plate by fat and fasciolata taken from the right thigh and followed by glue. Then the dura closed in the watertight and the epidural drain was fixed and the bone was fixed in position by suturing and the skin was closed in multilayer. Post-operatively, there is a stop of the CSF flake. This is the view of the post-operative CT scan. We show some hematoma in the bed of the mucocele. Drain was containing less than 30 cc blood. Patient was discharged in the 4th day post-operative day. 1 month later, patient presented to our clinic, have no complaint, no CSF flake. We have a small wound dehiscent in the right thigh, which was treated as a superficial infection and was recovered. There is a small hypodense area in the frontal, in the left frontal area, in the area of the mucocele. Now the patient doing well, have no complaint, and is for further follow-up. But our recommendation? Our recommendation, first of all, is complete external mucosa of the sinus should be removed to prevent further reaccumulation of the mucus secreted by the remnant of the mucosa in the sinus, which may cause another mucocele in a delayed fashion. The surgical indication for traumatic brain injury guidelines should be followed. As level 1 class 3 scientific evidence should be followed. And this is what is we described in relation to the frontal air sinus fracture, involvement of the anterior and posterior wall. If there is signs of dural involvement by pneumocephalus, CSF plaque, these all indication for direct surgical repair, and not just for simple repair of the skin, and let the patient go for more complication, including meningitis, which be lethal and more morbid for the patient, and also for a difficult reconstruction after a while from the injury. Thank you.
Thank you, Professor. Stephanie.
It's a short time, I know.
Okay. Stephanie Nicole is there?
Good afternoon, everyone. Nice to meet you. It's a great honor for me to be here. I'm Nicole Fuentes. I'm a fifth-year medical student from Bolivia. When I first got the invitation from Ahmed, I received his call a month ago, and I thought this idea was great of organizing this joint event as a way of introducing the Yemen neurosurgeons chapter. And I want to congratulate Dr. Adnan for always supporting the team in Yemen. I know he's always kept in touch with them. And I also want to congratulate Dr. Hisham for his great presentation, as well as Dr. Salim, and of course, Dr. Bennett, that he's always supporting us and lending us his platform, Neurosurgical TV, for this kind of events. So it's very nice for me to be here, and I want to congratulate each and every one of you.
Thank you, thank you.
Hello, Professor Adnan.
Yes.
How are you?
Fine, thank you.
Fine. I just want to thank Professor Adnan for this nice lecture. And I want to thank him because he always supportive for all the neurosurgical residents in Yemen. Thank you, Professor Adnan.
Thank you, my colleague. Thank you, my Dr. Ayman. You are a best friend. And we will do this for all the staff of our country and helping all the neurosurgical doctor and resident in our country for more educational purpose and for more continuous medical education.
Thank you. Thank you so much. See you soon, inshallah. Allah.
Okay, I would like to do something there. Professor Yuko Kato will join us, but she may take a few time to join us. So we will wait for her a few minutes. So you can keep asking and discussing till she joins us.
Hello.
Yes, so thank you. I would like to introduce Dr. Victor Hugo. He was raising his hand.
No, Dr.
Good afternoon,
Takashi
Doctor.
Kon wanted to make a question, Dr. Takashi Kon.
Okay.
Hello, good evening. Good evening. I'm Takashi Kon from Tokyo, Japan. Thank you for the nice lecture. So we sometimes encounter traumatic brain injury and CSF leakage, and very difficult to treat. And epidural or subdural abscess, sometimes very difficult to treat. We continue the antibiotics. In your experience, so doctor, so what is kind of antibiotics is mainly used for how long? You said that 1 week antibiotics will be enough, but what to cover? What kind of bacteria you're covering?
Already the patient was admitted in our ICU for about 1 month for treatment of meningitis. He was covered under triple antibiotic to cover gram-positive, gram-negative, and anaerobic bacteria. We are routinely use vancomycin, flagyl, and ciprofloxacin as routine antibiotic for this kind of infection. Unfortunately, the CSIP culture and sensitivity was negative for all his culture taken around all the months because he was already in the antibiotic, but CSIP flake is may decrease the severity of meningitis in this kind of trauma. So we always use the antibiotic to cover these three pathological important gram-positive and gram-negative bacteria and also anaerobic bacteria. The duration is for 1 week is that continuation for the previous 1 month. So the duration of the treatment, it was 5 weeks total. So we stopped after 1 week for this reason, as all the culture was negative. So we see that 1 week is enough.
Okay, thank you. So, and I want to leave another question. So, because in Japan was relatively safe and very few experience of stab wounds or gunshot wound. But as you know, the former prime minister was shot in gunshot. So we are very fearful about such kind of injury increasing. So I want to know how to manage the stab wound, the gunshot wound directly. And firstly, we have to prepare. So I want to learn about everything about head injury other than trauma, gunshot wound, or stab wounds. Thank you.
Thank you. Can you repeat your question, please?
Yeah, I want to leave a comment. So I have to prepare for the other than the head injury. So gunshot wound and stab wound by the knife. Because in Japan, unfortunately,
yes.
Yeah, in Japan, increasing and the former prime minister was shot. So we have to prepare for those management.
You know that this penetrating brain injury, where we have a lecture before maybe 1 month with the Cranial Neurosurgical Society about the penetrating brain injury. It's a big topic that's it's depending about the minimal debridement or if you will do a big debridement and all the modalities, that minimal debridement of the dura and the fragment and the skin wound is have a better prognostic effect than the diffuse debridement and the tract trajectory of the bullet or the stab wound or the knife debridement inside the brain. You will have more brain tissue damage. You will have more sequela, more consumption of medical support, and it's a time consuming. And for a better result, you will minimal debridement is the best for this kind of trauma.
Thank you. Yeah, thank you. Exactly.
You're welcome.
Okay, Ahmed, you there?
Yeah. Nicole, are you there?
Yes, I'm here.
Okay. When you contacted Professor Yuko? I mean, the last time you contacted Professor Yuko Kato.
So right now it's like 4 a.m., 4:15 a.m. And she said she would join at 5:30 a.m.
1 hour and a half?
Yeah.
Okay.
But we have to
time to wait.
I don't think I'll be able to come back. So I guess we'll have to wrap it up, Ahmed.
Okay, you can do it.
Unfortunately, I can't continue for another hour and a half, unfortunately. Sorry to say.
Should we start again?
Well.
What do you think, Nicole?
We'll talk about it later, okay? We'll examine what's going on. Okay. Or perhaps we'll talk about it. Maybe we could arrange a webcast tomorrow or something. Would that be okay? 'Cause I cannot do it today.
Okay.
How do you find Nicole?
I can ask her through her email. And Dr. Bennett, if you can tell us a time so that we convert it to Japan time and ask her on her email.
Yeah, it'll probably be tomorrow though, not today.
Okay.
Well, obviously it's too late in Japan now. So
Yeah.
So we'll straighten it out through email.
Should we postpone this presentation till another time or to tomorrow?
Yeah, I'll let you know.
I'm so sorry about this.
We'll try to shoot for tomorrow. We'll try to shoot for tomorrow.
Yeah.
Dr. Ahmed, I think it's to arrange it with another lecture is to be better, and to arrange it with for Japanese local time, for that Dr. can prepare herself and to be ready for the topic.
Actually, I'm so sorry about this, miss. I thought this may take longer time. So Professor Yoko is not wrong anyway. But anyway, I'm so sorry about this, miss, and about this problem. I'm so sorry.
That's okay. It was a good conference.
Thank you very much. I have to leave.
Thank you, Dr. Hisham. Thank you very much.
Thank you very much for your invitation.
Thanks everybody for
Thank you, everyone.
putting their free time in.
It was great. Everyone. Nice to meet you.
Goodbye.
See you, everybody. We'll keep in contact.
Nice to meet you all.
Goodbye.
Bye. Goodbye, everyone.
We will be in contact, John.
Okay, Ahmed.
Thank you.
I'll be in contact.
Okay.
And watch my email, watch my Facebook account. That's why I'll make the announcement, okay? Okay, Ahmed? Or I'll write to you directly. Okay?
I didn't hear you. What did you say?
I'll write to you directly. I'll text you directly.
Okay.
And let you know. Okay?
Okay, Zewish.